Good day. Today we will discuss endodontic treatment of temporary teeth and permanent teeth with unformed roots, endodontic tools and techniques, modern materials for obturation of root canals in pediatric dentistry. Pediatric endodontics, endodontic treatment for the primary and young permanent dentition. Despite the dental professionals' emphasis of prevention, risks to pulp survival, such as caries, restorative dental treatment, and traumatic injuries, have not been eliminated. As a consequence, children continue to lose teeth prematurely, and procedures aimed at preventing and treating pulp disease in the primary and immature permanent dentition remains an integral part of contemporary dental practice. Some may question why efforts to preserve pulpily involved primary teeth are important. These positions for dentists maintain that such efforts may present a risk to development permanent successors and in any case, the primary teeth will be lost before long. Preservation of arch space is one of the principal objectives of pediatric dentistry. Premature loss of primary teeth may cause aberration of the arch length, resulting in nasal drift on the permanent teeth and consequent malocclusion. Wherever possible, the tooth-will pulp involvement should be maintained within the dental arch in a functional and disease-free condition. Other aims of preserving the primary teeth are to safeguard aesthetics and mastification, prevent aberrant tone habits, aid in speech, and prevent the physiological effects that may be associated with tooth loss. Premature loss of the maxillary incisors before 3 years of age has been shown to cause speech improvement that may persist in later years. It is equally considerable for children to suffer the unplanned loss of permanent teeth. And it should be noted that the prognosis of lifelong retention of an immature tooth with a short root and fragile dental walls is far worse than for a major permanent tooth. Special treatments for unformed permanent tooth therefore focus on preserving vital pulp functions, at least until dental development is complete. The pulp dentine complex and primary and young permanent teeth. Pulp therapy should be based on an understanding of dental tissues and their innate reaction patterns. Some fundamentals of tissue structures and behavior merit review. You can listen during this lecture. Differences in primary and permanent tooth morphology. Successful pulpal therapy in the primary dentition required a tooth's understanding of primary pulp morphology, root formation, and the special features associated with physiologic resorption of primary tooth roots. These factors are considered in the following sections. First, according to Finn and Nelson, there are 12 basic differences between primary and permanent teeth. The first, primary teeth are smaller in all dimensions that correspond in permanent teeth. Primary crowns are wider in the mesial to distal dimension compared with the crown lengths that are permanent crowns. Primary teeth have narrowed and longer roots compared to crown lengths and whilst in permanent teeth. The facial and lingual cervical third of the crowns of anterior primary teeth are much more prominent than those of permanent teeth. Primary teeth are markedly more constricted in the dentin enamel junction than are permanent teeth. The facial and lingual surfaces of primary molars converge occlusally, therefore the occlusal surface is much narrowed in the facial lingual dimension than the cervical width. The roots of primary molars are comparatively more slender and longer than the roots of permanent molars. The roots of primary molars flare out from the cervical area and more at the apex than do the roots of permanent molars. The enamel is thinner, approximately 1 millimeter on primary teeth than on permanent teeth, and have a more consistent depth. The thickness of the dentine between the pulp chamber and enamel in primary teeth is less than in permanent teeth. The pulp chambers in primary teeth are comparatively later than those in permanent teeth. And the last difference, the pulp horns, especially the nasal horns, are higher in primary molars than in permanent molars. What about the root formation? According to urban development of the roots begins after enamel and dentine formation has reached the future cement enamel junction. The epithelial dental organs form calyx epithelial root sheath which initiates formation and molds the shape of the roots. Hertwig's sheath take the form of one or more epithelial tubes depending on the number of roots of the tooth, one tube for each root. During root formation, the apical foramen of each root had a wide opening limited by the epithelial diaphragm. The dentinal walls diverge apically, and the shape of the bulb canals is like a wide open tube. Each root contains one canal at this time, and the number of canals is the same as the number of roots. You can see this improvement on the slide. When roots length is established, the sheath disappears, but dentine deposition continues internally within the roots. In immature permanent teeth, it is often difficult to assess the extent of apical closure. Plain film images are frequently misleading because under normal conditions they show that mesodistal plane of the tooth, but give little information about the facial lingual dimension. Except for the maxillary, central, and lateral incisor, all other root canals of the permanent teeth are wider in the facial lingual plane than in the mesodistal plane. The facial lingual aspect of the root canal is 2 to 3 times as wide as the mesodistal wide, and if the blast will become convergent apically as the root develops. Therefore, it is possible to have a dental radiograph showing an apically convergent root canals, whereas in the facial lingual plane, the root canals is divergent equally canal that apically diverging in the facial lingual view may be parallel or converging in the mesodistal view. As mentioned, contemporary three-dimensional imaging techniques are being to improve understanding both in the research laboratory and in the clinics. Primary tooth root canal physiology and anomalies. Roots of the primary teeth will begin to resorb and as soon as the root length is completed. You can see the different types of Imagine the photography, the X-ray investigation, and 3D computed tomography. This resorption caused the position of the apical foramen to change continually. Because of accessory canals, intraradicular bone lesion in inflamed primary molars can be found anywhere along the root and especially in the furcation area. Other root canal anomalies or abnormalities that should also be taken into consideration include taurodontism, a tooth with an enlarged pulp chamber, apical displacement of the pulpal floor, and no constriction at the level of the cemento-enamel junction as characteristic features, single-rooted primary maxillary molars, or C-shaped canal orifice, but they do not require a modification of the pulpectomy technique. This in turn would not be dealt with separately. And Undestroyed radiograph before performing root canal treatment is essential to assess canal morphology. The radiograph performed before root canal treatment, in this case of the lower right second primary molar. You can see the smaller on your screen. The success of endodontic treatment depends on elimination of the infecting bacteria, though adequate root canal debridement, instrumentation, root canal instrumentation, antibacterial irrigations, and antibacterial filling materials. Root canal treatment is considered successful after a follow-up period. The tooth is not mobile, remains in function without pain, discomfort, or infection until the permanent successors is ready to erupt and undergoes physiologic resorption. Radiographically, the tooth should present absence or reduction in size or pre-existing pathologic radiolucent defects and no new lesions. Indications and contraindications for root canal treatment in primary teeth. Root canal treatment. mm, Root canal treatment in primary teeth is indicated when the radicular pulp exhibits clinical signs of irreversible pulpitis or pulp necrosis, while the roots show minimal or no resorption. Contraindication for root canal treatment or RCT in primary teeth are discussed lent highly in the different sources. Root canal treatment in primary molars is contraindicated in teeth with non-restorable crowns, perforation to the pulpal floor, serious reduction in bone support and or extreme tooth mobility, radiographic indication of extensive internal or external root resorption, periradicular radiolucency involving the follicle of the permanent tooth, and underlying dentigerous of follicular crests and of medically compromised children. Lateral and accessory canals exist in most primary molars and are more prevalent in mandibular molars compared with maxillary ones. Accessory canals in the furcation of primary molars can explain the frequent presence of radiolucency and the furcation area of necrotic of teeth. A RCT in primary second molar with a poor prognosis is sometimes indicated even If the tooth is maintained only until the first permanent molar has erupted, and then the primary molar is extracted and replaced with a space maintainer. What about root canal treatment techniques? The anatomic techniques, it is the best techniques for the root canal instrumentation. RCT in primary teeth may be completed in one visit. It's very important and necessary for understanding due to age of the children with primary dentition. Under local anesthesia and rubber dam isolation, caries is removed and access to the pulp chamber is gained. Excess and debridement. The inflamed or necrotic pulp is removed and excess preparation is refined to make sure that entrance to all of the canals is possible and clearly visible. I want to show you what that means. Visible root canals. Is visible. Primary molars roots are usually curved to allow for the development of the permanent tooth. During instrumentation, these curves increase the chance of perforation of the apical portion of the root and of the coronal 1/3. After each canal orifice has been located, a properly sized barbed broach is selected. The broach is used gently to remove as much organic material as possible from each canal. Endodontic files are selected and adjusted to stop 1 or 2 millimeter short of the radiographic apex with their preliminary working lengths estimated according to the preoperative radiograph or by apex locator. This instrument should be slightly bent to adjust to the curvature of the canals, thus preventing perforations on the outer and inner portion of the root. Perforations of the convex and concave aspects of a root of a primary molar caused by a injudicious of root canal instruments. Removal of organic debris is the main purpose of canal instrumentation. Please put your attention on the screen. You can see there special endodontic instruments for pediatric dentistry. Baby files. For endodontic handpiece and for the manually root canal instrumentation. And you can see that the lengths of these baby files shorter than the length of their standard endodontic instruments. The removal of organic debris is the main purpose of canal instrumentation. Mechanical removal of remnants from the canal is performed using a series of 21 millimeter long K-type endodontic files. The initial working length is estimated with the X-ray or another more contemporary apparatus named apex locator. When the file is inserted into the canal, the apical stop is felt with tactile sense, and this measurement is then compared to the radiograph. You avoid unnecessary shaping of the canals, since that can damage the tooth and lead to perforation in the furcation on the lateral walls. Mechanical removal of remnants from the canal is performed using a series of 21 millimeter long cut-type endodontic files. What about irrigation? It is necessary procedure for the root canal treatment and after root canal instrumentation. Disinfection with irrigating solution is an important step in ensuring optimal bacterial decontamination of the canals. The root canals are irrigated with either 0.2% up to 2% hexidine solution, or with 1% up to 5% sodium hypochlorite, limited to 1% sodium hypochlorite, according to the AAPD guidelines. The root canals are first irrigated with either chlorhexidine solution with the investigated concentration, or with sodium hypochlorite and then with normal saline. The use of sodium hypochlorite as a primary dentition should be performed courteously, since it is a potent tissue irritant and must not be extracted beyond the apex. Extruded beyond the apex. Sodium hypochlorite accident in a pediatric patient. Presentation in the post-anesthesia care unit. Presentation 1 day after the surgery. Presentation 2 days after surgery. A complete uneventful recovery 6 weeks after the surgery. Irrigation with normal saline before drying with the appropriately sized sterile paper points is also recommended. You can see these stages on your screen. There is insufficient evidence supporting the outright superiority of any specific individual irrigation material or irrigating regime, except anecdotal case report. No evidence-based studies reported any adverse effects, and it's not clear if there were known or that were just not reported, and thus the safety profile for each of the irrigating solution remains unclear. Filling the canals. What about filling the canals? First of all, lentil spirals, it is the filling instrument for obturation the primary root canals. The single instrument for obturation the primary root canals. Filling the canals. Put your attention on the screen. It is a table with different types of root filling materials. The instruments employed to fill the canals depend mainly on the material used. Thick paste such as zinc oxide eugenol is inserted and condensed with root canal pluggers, while the thinner paste like iodoform and calcium hydroxide based materials are inserted with a spiral lentil mounted on a slow speed engine. Other materials are inserted with plastic syringes and tips provided by the manufacturer. For example, plastic syringe. Insertion of paste with a plastic syringe. The ideal root canal filling material should resorb at the same place as the physiological resorption of the root. You can see this on the X-ray investigation after 6 months of endodontic treatment. B, non-toxic to the periapical tissues and to the permanent tooth germ, resorbs readily enforced beyond the apex, and B, antiseptic, easy to insert, non-shrinkable, and easily removed if necessary. A number of root canal filling materials can be used for primary teeth with no known ideal root canal filling material. This table describes various popular root canal fillers for primary teeth. According to the literature, the most adequate material appears to be a calcium hydroxide uniform mixture. Calcium hydroxide provides the high pH than 10 environment that the high pH environment that along with uniform has a high bacteriostatic effect. Zinc oxide eugenol paste. A zinc mix of zinc oxide and eugenol without settings accelerators may be pushed into the root canals using a situable root canal plugin. Zinc oxide eugenol tends to resorb at a slower rate than the roots of the primary teeth. So placing it in the root canals can create a problem to the clinicians. When extruded beyond the apices, the material sets into a hard cement that resists resorption. It appeared in the tissue after loss of the pulpectomized tooth in 49% of the cases. In the remain in the alveolar bone for months or years, 27% of cases after a mean time of 14 months. Remnants of zinc oxide eugenol may cause a mild foreign body reaction. The use of zinc oxide eugenol cements or pastes without setting acceleration has been previously recommended. Currently, the tendency is to use uniform calcium hydroxide filler. Zinc oxide eugenol paste extruded beyond the apices set into a hard cement that resists resorption. Left and center, the remnants of the zinc oxide eugenol are still present after the eruption of the permanent central incisors. Calcium hydroxide pastes with the uniform. The antimicrobial action of calcium hydroxide is associated with its ionic dissociation. The aqueous, viscous, or oily radical used in the formation of the root canal filling paste impact this speed of ionic dissociation. As aqueous radicals favor a high degree of solubility, they will cause depletion of the paste from the root canals before the time of the physiological root resorption. Viscous radicals promote lower solubility of the paste, and oily radicals have the lowest solubility and diffusion of calcium hydroxide paste, showing better results. Uniform containing paste, such as white apex, for example, are introduced into the root canal using disposable tips or a spiral intuler mounted on a slow-speed handpiece, and the teeth are sealed with reinforced zinc oxide eugenol. In the combination of 30% calcium hydroxide, 40% of uniform, and 22% of silicone oil. It is radio-packed, premixed, easily to use plastic storage tip, and remove and absorbed of inadvertently extruded past the apex. In primary teeth with irreversible pulpal changes, think of site-eugenol pulpectomies, zero outcomes as white apex, for example, are more favorable than seal apex. A calcium hydroxide cement, although there was no agreement with regard to filling materials resorption. When extruded in the focal or apical areas, this cement can either diffuse or be resorbed in 1 or 2 weeks. Bone regeneration has been clinically and histologically documented. Some scientists employed cultures of bacteria that have been reported to inhabit non-vital root canals of primary teeth and found that white apex didn't inhibit the growth of Streptococcus mutans, Streptococcus aureus, and showed no antibacterial activity against most pure cultures. A uniform-based paste. In vitro studies found that uniform-based paste demonstrated minimal inhibition of 23 strains of bacteria isolated from infected root canals of primary molars and 3 non-standard bacterial strains using agar diffusion. As I compared with zinc oxide eugenol paste and materials containing zinc oxide. Meister's paste, introduced in 1977, includes both zinc oxide and uniform with parachlorophenol, lanolin, and thymol. The presence of zinc oxide slows its resorption, and it was reported to have significantly higher success rates compared to zinc oxide eugenol alone. CARI paste is a mixture of uniform 80.8% camphor, parachlorophenol, and menthol. KRA paste shows strong antibacterial effectiveness than did zinc oxide eugenol against pure cultures of obligate anaerobes with bacteroids. Species and anaerobic streptococci isolated from non-vital root canal of primary teeth. Some supplementary methods: dental operating microscopes, electronic apex locator. 1 moment, please. I'll show you the examples of electronic apex locator. Rotary nickel titanium files and irrigation techniques are at the front of endodontic armamentarium today. The use of dental operating microscope is not essential with treating primary teeth. Preparation of root canals in primary teeth, contrary to permanent teeth, is based on chemical means rather than on mechanical debridement. When considering the use of electronic apex locator, only few studies exist, and most of them are either in vitro or studies performed under general anesthesia. Those studies recommend further evaluation of the useful of this electronic apparatus. As for other instrumentation techniques in primary molars, in vitro studies found equal cleaning capacity but reduction of instrumentation time by the rotary techniques. The use of the rotary technique reduces the time of instrumentation and obturation to 30 63 and 68% respectively, and also improved the quality of the root canal feeding. The reduction of root canal treatment procedure time is a relevant clinical factor in the treatment of children, but due to lack of an appropriate studies, it is not yet possible to recommend the use of rotary feeding techniques as a standard procedure. Some clinicians provided similar cleanly lines as lottery instrumentation technique and what the parallel to manual instrumentation. The laser techniques required the less time for completion of the cleaning and shaping procedures when compared with both rotary and hand instrumentation. Here too, due to the limited clinical studies, and the lack of adequate follow-up, this technique cannot be yet recommended for common practice, and so manual instrumentation is still the preferred debridement methods for root canals. In different dental schools and practiced by diplomas. Evaluation of root canal treatment. Root canal treatment is considered successful if clinically pre-treatment clinical signs and symptoms resolve within a few weeks and the tooth is painless, present in healthy surroundings of tissue, and no increased mobility. The treatment should permit resorption of the roots of primary tooth and filling materials and allow normal eruption of the permanent tooth. Radiographic lesions present preoperatively should resolve within 6 months, as evidenced by bone disposition and a decrease of or disappearance or at least no change in pretreatment radiolucent areas. No pathological resorption, furcation, apical radiolucency or new lesion should appear after treatment. Radiographically, success is defined either as when the radiolucency observed at the baseline didn't increase, or is a decrease in tides, or when there is no radiolucency in the focal or periradicular areas. In all trials, success rates were equal to or above 78%. Treatment is considered a failure when pre-existing radiolucent defects have growth in size or new defects appeared. A success rate of root canal treatment in primary teeth has been discussed in the literature in the last 15 years. Success rate were around 43 in early study that used different techniques that the average pulpectomy that is performed today. Later studies have reported success rates of 95 and 99%. More recent studies achieved a success rate of 82 to 90% for primary molars, root canal treatment with a thin coccygeal filling materials. The success rate of root canal treatment in the anterior teeth varied from 76 to 82.8%. When using carious paste, the rate of successful treatment with no clinical or radiographic signs of symptoms was form over 80% up to as high as 95.6%. Pulp therapy for the young permanent dentition or the tooth with a major roots. Vertical bite when also used the periapical radiograph can be used in order to demonstrate information provided by both types of radiographs. Deep carious and periapical radiolucency is observed in the mandibular permanent second mole. Periapical radiograph of the contralateral tooth showing normal apical papilla. Periapical radiographs should be inspected for continuity of the periodontal ligament in order to diagnose inflammatory and resorptive lesions. The interpretation of radiographs of young immature permanent teeth can be difficult due to their normally large and open apex and radiolucent apical papilla. Less experienced dentists treating these teeth should avoid confusing pathologic changes with a normal apical anatomy. In a young child, a radical bite win with a small size radiograph can be used instead of a periapical radiograph in order to see the periapical area of posterior teeth. A treatment decision is not always possible based on a single radiograph. Hence, a radiograph of the antimeter or is frequently taken or comparison. The degree of root development of the affected tooth and the amount of dentine position along the canal should be compared with those of the contralateral tooth. It is important to remember that the root canals or permanent teeth are wider in the buccal-lingual plane than the mesodistal. Therefore, it is difficult to determine the extent of apical closure in a regular radiograph showing only the mesodistal plane, as you can see on your screen. In anterior region, radiographs of each central incisors should be obtained separately from a distal angulation to prevent overlapping of the periodontal ligament of the central incisors over the lateral incisors. Performing radiography in this manner is often important in teeth after traumatic injuries. A lateral external inflammatory root resorption is a common finding in necrotic young teeth after trauma. External replacement root resorption can also be seen after traumatic injuries. I want to describe a few clinical cases and the methods of endodontic treatment in every case. 9-year-old girl, 4 days post complicated crown fracture in the right maxillary permanent central incisor. Radiographs of the maxillary central incisors. Immature root with open apices and wide root canals can be seen. The right maxillary central incisor after cleaning ended infection with sodium hypochlorite solution. A small pulp exposure is seen. Partial pulpectomy, white MTA pro-root as pulp capping material. Glass ionomer cement placed on top of the MTA. 2-year follow-up. Gray discoloration caused by the white MTA is seen in the crown. Continuous root formation and apical closure is evident in the radiograph. In recent years, the use of cone beam computed tomography is in endodontics has significantly increased. CBCT is a technique that produces undistorted three-dimensional digital imaging of the teeth and their surrounding tissue. It reduces cost and less radiation for the patient than traditional CT scans. The World Association of Endodontic and the American Academy of Oral and Maxillofacial Radiography state that the use of CBCT is justified in causes in which the benefits to the patients outweigh the potential risk of exposure to X-ray, especially in the case of children or young adults. CBCT should only be used when the questions for which imaging is required cannot be answered adequately by lower dose conventional dental radiography or alternate imaging modalities. Direct pulp evaluation. In some instances, during the clinical treatment, a final diagnosis can only be reached by direct visualization on the pulp tissue. The appearance of the pulp tissue and the core and the amount of bleeding from a direct exposure of the pulp must be assessed. Profuse or deep purple-colored bleeding or pus exudate indicates irreversible pulpitis. Based on this observation, the treatment plan may be confirmed or changed. The different procedures of vital pulp therapy for immature permanent teeth have much in common with those of primary teeth and include indirect and direct pulp capping, partial pulpectomy, cervical pulpectomy, and epixagenesis. As mentioned in young permanent teeth, all the efforts is made to preserve total or partial vitality of the pulp. Treatment procedures for non-vital immature permanent teeth will be presented further on this lecture. The vital pulp in primary dentition, primary teeth, and permanent in young permanent dentition with unformed roots, it's very important part of the tooth development. Vital pulp therapy for normal pulp or irreversible pulpitis without pulp exposure. Indirect pulp treatment, IPT. Carious excavation and indirect pulp treatment for immature permanent teeth is similar to that of primary teeth. The main objective of indirect pulp treatment is to maintain the vitality of teeth or teeth pulp with deep caries and visible pulpitis. That otherwise need endodontic therapy if the decay was completely removed. The indication for IPT should be limited to teeth without signs of irreversible pulpitis. Clinically, during cavity preparation, the demineralized carious tissue is removed and a thin layer of carious is left on the pulpal floor. At the carious tissue is removed and a thin layer of carious at the deepest side of the cavity to avoid pulp exposure. The carious tissue is then covered with a biocompatible material. The material most commonly used in IPT calcium hydroxide, glass iron and mineral trioxide aggregate. The tooth then is restored with the material that seal the tooth from microleakage. Two clinical procedures have been described in the literature. One appointment carious excavation and a stepwise technique, 2 appointments. Research available is inconclusive on which approach is the most successful over time. Several studies have demonstrated a high percentage of success utilizing IPT both in permanent and primary teeth. Some authors demonstrated that in symptomless vital carious primary or permanent teeth, stepwise and partial excavation reduced the risk of pulp exposure. Therefore, their techniques show clinical advantage of a complete caries removal in the management of dentinal caries. Vital pulps therapy for normal pulp or reversible pulpitis with pulp direct pulp capping. What that mean? Or biological methods of endodontic treatment. Direct pulp capping may be performed when a small exposure of the pulp encountered during cavity preparation in teeth with a normal pulp or reversible pulpitis, or following a recently sustained traumatic injury. The aim of this treatment is to maintain pulp vitality by forming a calcified barrier reparative dentine to wall off the exposure. It should be kept in mean that it is affected by caries. There is an inflammatory response of the pulp to bacteria or bacterial products. Direct pulp capping should be performed immediately after the exposure to prevent contamination of the pulp by microorganisms which exist in the oral cavity. At the extent of the inflammatory process in the pulp cannot be accurately assessed by clinical test. The diagnosis of the reversible treatable pulpitis might be sometimes incorrect. In some teeth affected by deep caries, pulp inflammation might have reached the stage of irreversible pulpitis without showing clinical signs. The characteristics of the pulp capping material are of significant importance. It should be ideally be biocompatible, non-resorable, capable of establishing and maintaining a good seal to prevent bacterial contamination, and capable of promoting pulp repair and dentine bridge formation. Ideally, the dentine bridge formed after direct pulp capping should be without tunnel defects and could allow the penetration of bacteria into the pulp at a later stage. Mineral trioxide aggregate and calcium hydroxide are the most frequently recommended capping materials. The mechanism of action of the two materials in vital pulp treatment are similar. And the main soluble component of mineral trioxide aggregate is calcium hydroxide. Calcium hydroxide dissolves in a aqueous environment into calcium and hydroxyl ions, creating the high pH in the closed environment. This alkaline pH is responsible for the bacterial activity of this material. These initial effects of calcium hydroxide applied to the exposed pulp tissue in the development of superficial necrosis as a result of the high pH. This necrosis causes low-grade irritation to the tissue and stimulates the pulp to defend and repair. Contrary to calcium hydroxide, MTA causes mild inflammatory and necrotic changes in the subjacent pulp. Thus, it is less caustic, caustic than the traditional calcium hydroxide preparation. Calcium ions are realized from the capping material, forming inorganic precipitation that have been associated with the mechanisms controlling cytological and functional changes in their interacting pulpal cells. The high pH and low solubility of the calcium hydroxide prolonged its antibacterial effects. However, being water soluble, it might dissolve under glyceration and be washed out, leaving the empty space under the filling material. Hard settings, calcium hydroxide cement can induce dentine breach formation, but they don't provide an effective long-term seal against bacteria of their byproducts. Recent studies suggest that the mechanisms by which calcium hydroxide or MTA stimulate the wound healing process is related to the solubilizing effect of calcium hydroxide on the dentine matrix component. Growth factors and other bioactive molecules sequestered within the dentine matrix during dentinogenesis. For example, TGF factor may be realized by the action of calcium hydroxide and mitigate the changes in cell behavior observed during reparative dentinogenesis. MTA presents some advantages over calcium hydroxide as the material of choice for direct pulp capping. It is hard settings biocompatible material with an antibacterial effect that provides a biologically active substrate for cells attachment. These features make this material effective in preventing microleakage, improving the treatment outcome. As previously mentioned, MTA stimulates reparative dentine formation with reliable pulpal necrosis and minimal inflammatory reaction in the exposed pulp. Some authors demonstrated that after direct pulp capping with MTA in dogs, the underlying pulp tissue was consistently normal, and only at a later stage some hemorrhage in the pulp core was observed. The beginning of a gut tissue barrier was observed after 2 weeks, and reparative dentinogenesis was disclosed after 3 weeks, associated with a free fibro dentine matrix. It was also demonstrated that compared with calcium hydroxide, MTA consistently induced the formation of dentine bridge at a greater rate with a superior structural integrity. Therefore, MTA appears to be more effective than calcium hydroxide for maintaining long-term pulp vitality after direct pulp capping. However, MTA, I want to back to previous slide. However, FTMA present a major drawback by staining tooth material both in the gray and white versions. Hence, its use in vital pulp therapy procedures, pulp capping, pulpotomy, is not recommended in teeth where there is an aesthetic concern. In these teeth, alternatives to MTA, that is calcium hydroxide, should be considered. Biodentine, for example, the new generation calcium silicate-based material, SMTA, which is described by the manufacturer as bioactive and biocompatible dentine substitute. It was introduced to the dental market and its properties have been described as similar to MTA. Its main advantage over MTA is its short setting time, at around 10 minutes, which enables the completion of some clinical procedures in one visit or maximum two. It also appears that biodentine doesn't cause tooth discoloration, but further studies are needed in this matter. During pulp capping should always be followed by an immediate and definitive restoration. About during pulp capping technique. The tooth should be isolated with a rubber dam and disinfected with sodium hypochlorite solution. During cavity preparation, with high-speed burrs under constant water spray and carious removal with low-speed burrs. I want to show you these special burrs for access is such instruments for access cavity preparation. The cavity should be rinsed with sodium hypochlorite from time to time to decrease the bacterial load. Now for the pulpal tissue is removed except that occurring with the carious removal. Pulpal hemorrhage is controlled by copious irrigation with with the hypochlorite solution. The solution is refreshed every 3-4 minutes and may be left in contact with the exposed pulp tissue for about 10 minutes. Hypochlorite disinfects the cavity and remove the blood clot from the pulp exposure site. Care should be taken to remove the blood clot prior to placement of the dressing material over the exposed pulp, and its presence may compromise the treatment outcome. It has been demonstrated that leaving the blood clot may result in the formation of dystrophic calcification and internal resorption. It may also interfere with dentine breach formation and thus substrate for bacteria and leaky restoration. Hypochlorite appears to have hypochlorite solution appears to have no adverse effect on pulpal healing and dentine breach formation. If the bleeding cannot be controlled within 10 minutes, it appears that the pulp formation is more extensive and has progressed deeper into the tissue. Therefore, a tooth initially scheduled for direct pulp cape may be a better candidate for pulpectomy. After hemorrhage control, MTA or calcium hydroxide should be prepared according to the manufacturer's instructions and placed directly over the exposed pulp tissue. 1.5 to 2 millimeter thick. The material should be then be covered with a glass ionomer liner followed by a permanent restoration with an excellent sealing ability. Pulpotomy. Although the use of direct pulp capping and pulpotomy in carelessly exposed pulp or matter teeth remains a conventional issues in endodontics. These procedures are universally accepted in young and mature permanent teeth. The pulpotomy procedure involves removing pulp tissue that has inflammatory or degenerative changes, leaving intact the remaining clinically appearing healthy tissue, which is then covered with a pulp capping agent to promote healing at the amputation site. The only difference between pulpotomy and pulp capping is that in pulpotomy, additional tissue is removed from the exposed pulp. Traditional pulpotomy implied the removal of the entire coronal pulp up to the cervical area. Today, the depth of tissue removal is based on clinical judgment. Only tissue with profuse bleeding judged to be inflamed or infected should be removed, and the capping material should be placed on healthy tissue. Although many materials and drugs have been used as capping agents after pulpotomy, MTA seems to be a treatment of choice to stimulate dentin bridge formation in young permanent teeth with exposed pulp. In aesthetic areas, MTA is not recommended because of its discoloration effect. Calcium hydroxide may be used as its outcomes are similar in some studies. Aguirre reported that partial pulpotomy and full cervical pulpotomy provide a more predictable outcome than direct pulp capping in teeth with carious lesion. Partial pulpotomy technique. Partial pulpotomy was first presented as a treatment modality for traumatic pulp exposures after a complicated crown fracture. These authors have shown that in untreated traumatic pulp exposures, the pulp inflammatory reaction is usually proliferative hyperplasia, and the inflammation extends not more than 2 millimeters into the pulp tissue even after 7 days. Therefore, they recommended that not more than 2 millimeters of the pulp beneath the exposure needs to be removed in these cases. The tooth should be isolated with the rubber dam. The tooth should be isolated with the rubber dam and disinfected with hypochlorite solution. Intraumatically exposed pulp, only tissue due to be inflamed should be removed at around 2 millimeters. In teeth with carious lesion or demineralization, it might be necessary to remove tissue to a greater depth in order to reach non-inflamed pulp. Care should be taken to remove all the tissue coronal to the amputation site to prevent continuation of bleeding, contamination by microorganisms, and discoloration of the tooth. Cutting of the tissue with an abrasive high-speed diamond bore with water cooling has been shown to be the least damaging of the underlying tissue. After pulp amputation, the preparation is thoroughly washed with hypochlorite of chlorhexidine solution, disinfect and control a hemorrhage. If hemorrhage persists, amputation should be performed at a more apical level. Once hemorrhage has been controlled, a dressing of MTA or calcium hydroxide in aesthetic areas in gently placed over the amputation site. Care should be taken not to push the material into the pulp. Restoration should be placed. If the pulpotomy is successful, a territory dentin bridge will be formed and gestational pulp obliteration may occur. Cervical or full pulpotomy. What that means? Cervical pulpotomy in metateeth is performed only when irreversible pulpitis is diagnosed. and it should be considered as an emergency treatment. In this case, root canal treatment with follow and next appointment. In immature permanent teeth, cervical pulpotomy is performed to allow maturation of the root. This procedure is performed in teeth in which it is assumed that healthy pulp tissue, with the potential to produce a dentine bridge and complete deformation of the roots, still remains in the root canal. I can show you the image of the dentine bridge. What that means. Dentine bridge is formed after apexification when it's necessary to provide root canal treatment. And the same dentine bridge you can see in the area of the pulp chamber in the crown. In immature permanent teeth, cervical pulpotomy is performed to allow maturation on the root. This procedure is performed in teeth in which it is assumed that healthy pulp tissue with the potential to produce a dentine bridge as complete the formation of the root still remains in the root canal. For example, the clinical case, 9 years old girl, first right lower permanent molar with a very deep carious lesion. The tooth is asymptomatic and respond with mild pain to all tests. Radiographically, and immature roots with very open apices are observed. After cervical pulpotomy, a white MTA is seen in the canal or orifices covered with a layer of glass ionomer cement. The crown was restored with composite filling material. 2 years follow-up, continuous root maturation is evident with no signs of apical ptosis. The technique for cervical pulpotomy is similar to that for partial pulpotomy, except for the level of pulp tissue amputation. In cervical pulpotomy, the entire corneal pulp is carefully amputated using a sharp excavator or a slow-speed large round burr to the level of the canal orifice. MTA or calcium hydroxide is used as dressing material in order to maintain pulp vitality and function. It is of utmost importance to perform a permanent restoration as soon as possible to prevent bacterial leakage and ensure the success of the treatment. Cervical pulpotomy is frequently performed in teeth in which the histopathological status of the pulp stumps is not clear. If the symptoms continue and pulpectomy is needed, the MTA may be removed gently using an ultrasonic instruments and an operative microscope. Follow-up after little pulp therapy. Clinical and radiographic follow-up of these teeth is essential because the pulp necrosis, canal obliteration, and root restoration are possible sequelae of fetal pulp therapy. No adverse clinical signs or symptoms or sensitivity, pain, or swelling should be present. Radiographically, no signs of internal or external resorption, no periapical radiolucency should be found. The roots should show continued normal development and metrogenesis in teeth with incompletely formed roots. In some cases, continuous calcification of the root canals is noticed after vital pulp therapy. And there is controversy whether root canal treatment is indicated after achieving a root maturation. Before obliteration of the root canal space occurs that will prevent performing root canal treatment in the future. Routine prophylactic endodontic treatment is contraindicated because of the lower percentage of pulp necrosis. Root canal treatment can be considered in posterior teeth where epicectomy is difficult to perform in causes of treatment failure, especially in children. What that means, epixogenesis? Epixogenesis, it's a very important stage in endodontic obturation in permanent teeth with unformed, uncompleted root formation. Epixogenesis, it indicates in immature permanent teeth when the inflammation of the pulp tissue is considered to be so deep that only part of the tissue inside the root canal is presumed to be vital and healthy. This procedure allows continued physiologic development and maturation of the root apex apical to the dressing material. The root formed may be irregular, but nevertheless provides additional support of the tooth. Epixogenesis can be clinically regarded as a very deep pulpectomy, therefore the technique is similar. The use of the operative microscope is recommended in order to execute this meticulous procedure correctly. MTA or calcium hydroxide is placed over the pulp stump after hemostasis control with the natural occlude. For example, the 7-year-old boy first right lower permanent molar with a very deep carious lesion. Radiographically, an image root with very wide blunderbuss-shaped open apices and are observed. After removal of pulp tissue from the pulp chamber and the coronal part of the canal tissue, judged to be non-inflamed, was seen with the help of the operative microscope. White MTA was placed on the healthy tissue. On the next visit, the MTAs was found to be hard and gutta percha and sealer were used to obturate the coronal part of the canals, only coronal part. 4 years follow-up. Complete development of the apical part of the roots is seen with no evidence of periapical patosis. It is difficult to determine the pulp status deep in the root canal or to predict the formation of a calcified barrier and continue root development. Clinical and radiographic follow-up is mandatory. If signs and or symptoms of pathology appear, apexification or pulp regenerative procedure should follow. The use of MTA as a dressing material should be carefully considered because of the difficulty in removing the material from deep inside the root canal. Non-vital pulp treatment for immature teeth. With the unformed roots. Epixification is the method of treatments for immature permanent teeth in which root growth and development cause ceased due to pulp necrosis. Its purpose is to induce root and closure by forming a calcified barrier with no canal wall thickening, no non-continuous root lightening. And the Gertwig's epithelial root sheath is absent. As previously mentioned, diagnosing pulp necrosis in hematodes can be challenging due to confounding factors such as normal radiographic radiolucency visible at the root and these the unreliability or sensibility test. Epic should only be performed when the diagnosis of pulp necrosis is certain. It can be achieved in two ways. The traditional long-term procedure using calcium hydroxide dressing to stimulate the formation of the biologic hard tissue barrier, and the more recently short-term procedure, creating an artificial apical plug with MTA. Apexification is most often performed in anterior teeth that lost vitality due to a traumatic injury or a deep carious lesion, and in the teeth with anatomic variation such as dents, invaginatus with an immature root. The open apex of hematodes may present a few morphological variation. It can be divergent with flowering apical foramen, blunderbuss apex, parallel or convergent. The exact morphology is difficult to determine because of the two-dimensional image obtained by dental radiographs. In all of these endodontic treatment can be performed, and it's difficult, if not impossible, to achieve the apical seal and will prevent extrusion of the filling material. Follow-up should be performed in order to ensure the absence of adverse post-treatment clinical symptoms and or radiographic signs of pathology. When the procedure is carried out successfully in teeth with radiographic signs of rarefying or states, it is healing of the bone will be absorbed gradually. The tooth will continue to erupt, and the alveolar bone will continue to grow in conjunction with the adjacent teeth. Publication in the last decades present an alternative treatment to opacification, the form of pulp regenerative therapy, even in cases of infected necrotic immaturities. This will be discussed in the further. Long-term epixification with calcium hydroxide. Epixification is traditionally performed using a calcium hydroxide dressing. It is predictable procedure, and an apical barrier will be performed in 74 to 100% of cases. It's very positive results. This procedure demands multiple visits and requires patient and parent compliance as it could take a year or more to achieve a complete apical barrier that would allow a good aperture root canal filling. It is unclear whether the stage of root development and at the beginning of the treatment of the presence or pre-treatment infection up to the time required for barrier formation. 8 years old girl, first right lower permanent mole with a deep caries. Lesion and buccal sinus tract. Radiographically, a large radiotranslucent lesion around the roots and the bifurcation is seen. Tracking radiograph with good aperture master cone leads to this area. Radiographic appearance after packing of the canal with the calcium hydroxide paste in the second visit. The roots look obliterated because the radio opacity of the thick calcium hydroxide paste resemble that of dentine. 6 months after calcium hydroxide packing, the radiolucent area is almost completely resolved and the calcified barrier is seen in the apical area of the canals. Final radiograph 2 months after calcium So after the last week, the showing obturation of the root canal with gutta-percha and sealer. Calcium hydroxide assists in the debridement of the root canals as it increases the dissolution of necrotic tissue when used alone or in combination with hypochlorite solution. The high pH and low solubility of calcium hydroxide keeps its antimicrobial effects and the root canal for a long period of time. Disagreements still exist as to whether or how often the calcium hydroxide dressing should be changed. Some investigators support a single application of the material and claim that it's only required to initiate the healing reaction, while others propose to replace the calcium hydroxide only when symptoms develop or if the material appears to have been washed out of the canal when viewed radiographically. The calcified barrier is formed by cells originated from the adjacent connective tissue, but the mechanism of action of calcium hydroxide in induction of an apical barrier remains controversial. The calcified barrier, although appearing clinically and radiographically complete, is histologically porous and may be composed of the cementum, dentine, bone, or osteodentine. The most served complication of calcium hydroxide apexification is cervical root fracture. Studies have shown that long-term dressing that would expose root dentine to calcium hydroxide for periods exceeding 1 month result in structural changes in the dentine with higher uh, flexibility of root fraction. A calcium hydroxide apexification technique. Rubber dam isolation is mandatory. The coronal axis should be wide enough to include the pulp forms to prevent further contamination and discoloration. In anterior teeth gate, Glidden drills can be used to remove the palatal eminence in the cervical portion of the root canal, facilitating cleaning of all aspects of the canal. The length of the root canal should be determined radiographically with a large gutta-percha point or endodontic files and electronic apex locators or with an electronic apex locator. Inserting a large size paper point to the point of bleeding may also assist in length determination. The working length should be approximately 1 millimeter short of the radiographic root end. For example, 10 years old boys, 10 months post-dental trauma. The upper right central incision present clinical symptoms with negative response to cold test. Radiographically, an image root with open apex and radiolucent periapical lesion is observed. Working lens with gutta-percha point 1 month after debridement and dressing with creamy calcium hydroxide paste. MTA apical plaque placement. Set wide MTA apical plaque 1 month after its placement. Permanent restoration with bonding of glass fibers in light curing resin matrix is performed in direct contact with the set MTA plaque. 2 years follow-up. Complete resolution of the apical radiolucency is evident. Debridement of the root canal is mainly achieved by irrigation with natrium chlor solution. Utilized its excellent tissue dissolving properties and its antimicrobial efficiency. The irrigation should be done carefully without pressure, verifying the needle is lost inside the root canal and show the working length. ensure the working lens. Passive or ultrasonic, for example, it may be passive ultrasonic irrigation with natrium or chlor solution, and recommended in order to facilitate disinfection and debris removal from these wide canals. Minimal or no instrumentation is adverse to prevent damage of the thin dentine walls. A calcium hydroxide dressing in a ceramic consistency can then be applied into the canal space with a lentular spiral, specially designed syringes or vials. A second visit is scheduled 2 4 weeks later. It's aimed to complete the debridement and remove the tissue remnants denaturized by the calcium hydroxide dressing that could not be removed mechanically in first appointment, and to further disinfect the canal. After disinfection, a thick paste of calcium hydroxide is packed in the root canal using endodontic pliers. The dressing packed into a level apical to the cemento enamel junction in order to reduce dentine we whitening in this fracture-sensitive area. The coronal access should be restored with a filling that provides a long-term coronal seal. The tooth should be monitored clinically and radiographically at 3 months intervals to examine the formation of an apical hard tissue barrier and ensure the absence of pathologies. If a calcified barrier is not evident and the calcium hydroxide has been washed out, its replacement is usually indicated. When a calcified barrier can be seen on the radiograph, the tooth is reopened and the calcium hydroxide is removed by copious irrigation. The apical area should be gently examined using a good aperture point and the operating microscope in order to determine the completeness of the apical barrier. If the barrier is incomplete, the epixification procedure is re-established until a complete barrier is formed. After the formation of a complete apical barrier, the canal is obturated with a permanent root canal filling material. For example, thermoplasticide, good aperture, or thermofill system, and sealer. When a classified barrier is formed coronal to the apex, it should not be perforated in order to fill the canal to the apical end. The tissue forming the apical barrier should be regarded as healthy tissue, and root canal filling should be placed up to this point. Immature tissue with the unformed roots and with the thin dentine walls, especially after calcium hydroxide epixification, are at high risk of fracture. The stage of root development seems to be a key factor. In order to reduce these risks, a permanent restoration with an intracanal placement of bounded composite resin is recommended. And a few words about short-term epixification with MTA, one visit epixification. The use of MTA as an artificial apical plug instead of the long traditional epixification with calcium hydroxide is widespread for more than a decade. Its main advantage lies in reducing the time needed for completion of the root canal treatment and the restoration of the tooth. An artificial apical barrier is placed in one visit while the whole treatment is completed in just few or frequent visits. Characteristics such as low solubility, excellence sealability, biocompatibility, reliance of calcium hydroxide, high pH and radiopacity are responsible for their preferable clinical results and popularity of MTA as an apical plug materials for the short-term epixification. Thank you for the attention and goodbye.